Colonoscopy is the gold standard and the best way to screen for colon cancer, period.
Welcome to Living Real Change, a podcast from Piedmont Healthcare. I'm your host, Dr. Lacey Knight, Chief Health Information Officer here at Piedmont. Join us as we highlight the people, the stories, and ideas that are transforming care and strengthening communities across Georgia. From inspiring patient journeys to expert health advice, each episode offers insight, hope, and a closer look at what real change looks like in healthcare today. Colon cancer is one of the most preventable forms of cancer, yet rates are rising among younger adults. In this episode, we're joined by Dr. Sam Atallah, a board-certified colon and rectal surgeon and an international leader in the treatment of colorectal cancer. Dr. Atallah shares how advances in minimally invasive and robotic surgery are transforming recovery and outcomes for patients. We also discuss why colorectal cancer is increasing in people under 50, what warning signs people should never ignore, and why screening remains one of the most powerful tools for prevention. Finally, Dr. Atallah explains what each of us can do through lifestyle choices, diet, exercise, and early screening to reduce our risk and protect our long-term health. Can we start with just a brief history of your journey into your specialty? What brought you into colon and rectal surgery?
Yeah, so I graduated medical school in 2000, but at the time that I trained, to give you an idea, there was no robotic colorectal surgery being done. And so it wasn't until my postgraduate years that I actually picked up and trained in robotics and other advanced techniques, some of which I actually developed. But we've seen it as a whole in terms of the practice of colon and rectal surgery. We've seen a phenomenal growth in what we term minimally invasive techniques.
Just a quick question on that. So when you say minimally invasive, what does that mean for a patient?
Minimally invasive is defined as small points of access or so-called keyhole access. To put it in simple terms, rather than being cut up and down all the way through your belly, small, sometimes just 5 millimeter incisions are made as points of access into the abdominal cavity. And through these keyhole points of access, we're able to administer or introduce small, sophisticated tools, if you will, or instruments that allow us to do the operation without big incisions. So what does that also translate to? Certainly better cosmetics, but what the things that patients also care about is they don't have to spend a lot of downtime, a lot of time in the hospital, so they can recuperate quickly and have a sort of a more successful experience having intestinal surgery.
That's super interesting. So it sounds like if for those that suffer from colon cancer, the ways of getting through that with surgical techniques have advanced significantly, where the recovery is sped up. Maybe you could talk a little bit about how either the diagnosis or the prevention or the information around kind of the precancerous conditions may have changed in the last couple of decades.
Before we get onto that, there's one other important aspect of the technology that has also evolved. And I'm proud to have been an innovator in this and proud to have kind of introduced this to my surgical specialty. And that is the development of transanal minimally invasive surgery. So what is that exactly? Well, all those things that we talked about with keyhole access and small incisions and quick recovery, they're even multiplied much greater when we use this technique called TAMIS. What is that? Essentially, we use the anus as a natural orifice point of access. So rather than going through the abdominal wall to get to our target, our tumor, we can go transanally and essentially carve the tumor out. This is a huge difference in terms of recovery. Now, forget about it. There's no scars at all in the abdomen. Oftentimes, this can be done as a day surgery setting, so it's outpatient, and patients' outcomes are still very good. Now, there are a few caveats with that. It's not for every patient. It's for early stage cancers of the rectum, and they have to be very select early stage cancers. But the fact is during my training, this didn't really even exist. So add that to the kind of the list of great new technologies that we have. We have laparoscopy, we have robotics, and the robots are getting better and more precise and more sophisticated.
That's awesome. Let's talk about a little bit about how the what we know about the development of cancer or the prevention pre-cancer, or maybe even what's changed with screening over the last couple of decades, and then from there we'll walk into prevalence trends and that type of thing.
Yeah, that's great. Okay, so let's talk about where does colon cancer really come from? A lot of our work early on through the 50s, 60s, up into the 90s was based on figuring out, well, where does a colon cancer arise from? And we know, and it's been well shown through many studies, that colon cancer develops as a benign growth known as a tubular adenoma and other polyps, basically. So it starts out as a benign polyp. How do we know that? Well, that really um, it comes from bench science research that has been done that shows that there's a sequence where these polyps can grow and grow and grow and transform over time into cancers. And we know this in studying certain relevant clinical conditions, one of which is familial adenomatous polyposis syndrome, a condition where someone may be inflicted with hundreds and hundreds of polyps. And we know the natural history of that.
Hmm.
Untreated, those patients universally, 100% of them will go on to develop colon cancer. This tells us that cancer arises from a polyp. So, knowing this information, we understand that the best way to screen for cancer, which is colonoscopy, it's the gold standard still in the United States, especially. It not only screens for a cancer, but we have a very important advantage that we can identify these tiny polyps and remove them, preventing them into from ever evolving into a cancer. So it's both then diagnostic and also, and we say in medicine, therapeutic, because we're nipping it in the bud, so to speak. We're removing that polyp before it ever has a chance to develop into a cancer. So we understand the problem. We know how to fix it, and we know that screening colonoscopies essentially saves lives.
With that in mind, I'm going to maybe shift the kind of conversation just to go a little bit further into screening because obviously I'm in the medical field and I've known about the screening colonoscopies. I probably take for granted how intimidating that is for patients to one undergo a procedure, two drink the prep,
Right.
and three there's a psychological deterrence to maybe even go undergoing that. Are there other ways to screen for colon cancer that
So this is a great question, and I actually want to get into it, and I want the patients to actually turn up the volume right now because this is really important. And the take home here is the same. Colonoscopy is the gold standard and the best way to screen for colon cancer, period. Now, I want to explain why that is. Recently, over the last 5 plus years, it's been longer actually, a option, most famously known as Cologuard, has arisen as an alternative. And, this is looking for tumor DNA. Okay, so it's a test, it's a stool test that looks for specifically tumor DNA. So let's think about DNA for a second. Now, you all probably know we each have our own unique DNA, right? I have my DNA, it's like I also have my unique thumbprint, and we all have a unique DNA. Guess what? Tumors also have a unique DNA signature, and we can assay for that. We can look for that, we can find that, and then we can know whether or not you perhaps have a tumor or you don't have a tumor. So that's the whole impetus behind this relatively newer test called Cologuard. And I will tell you personally, because I sat on the advisory board for Cologuard when they wanted to launch this. So I looked at the clinical data, and I can tell you, based on that clinical data, what are the downsides of why this should not be the first step go to for screening. And the first and foremost of which is all those polyps that I just got done telling you about, if you can remove them, you prevent cancer. Well, Cologuard doesn't remove polyps. Moreover, Cologuard is not designed to detect polyps whatsoever. So if your colon has multiple polyps in it, that is not going to be revealed by a Cologuard test. That test will just show negative. Secondly, in early stage colon cancer, early stage cancers of most types are the ones we can cure with the highest degree of certainty. So, with early stage 1 colon cancer, Cologuard misses a large fraction of those. So, it can't detect early stage very well. It can detect late stages. Finally, the last piece of the puzzle that sort of makes this not the first best option is if your Cologuard is positive, guess what? You need a colonoscopy, and somebody's got to then finally do the actual gold standard test. So, all right, having said all this kind of negative things about Cologuard, and I'm not trying to poo poo it, I do think it has a place in medicine. The value of this is for those people who are not getting screened for whatever reason, can we give them a valid alternative? Okay, it's not as robust of a screening as colonoscopy, but it's better than nothing. Yes, absolutely. So, and that is the value of Cologuard.
At Piedmont, quality care changes lives. Meet Tom, a lifelong medic who suddenly suffered a stroke at home. Tom was diagnosed, treated, and in surgery within minutes, thanks to seamless coordination across the entire care team.
I've seen firsthand how every second counts. When I needed help, Piedmont moved with speed and precision, and that saved my life. A week later, I was back at home with my family, back to work and back to living.
Hear more at piedmont.org/qualitycare. Piedmont, real change lives here.
Let's switch to maybe talking about prevalence a little bit. So what is, we hear a lot about advances in cancer treatment across the board, ability to treat and cure, diagnose cancer. What's the current scenario around colon cancer today? How big is the problem?
That's a great question. So let's talk about the problem, the scope, the nature, and the shifting trends that we're seeing. You probably have heard this because it's making headline news at this point. Look at all the major news networks, and they're talking about stories not only of, celebrities, if you will, that have been afflicted and have, succumbed to colorectal cancer. James Vanderbeek, for example, recently from Dawson's Creek, but there are many others that sort of highlight this in the media. But let's actually talk about this because it is a problem, and it's a problem that we don't fully understand, meaning we don't understand this trend that we're seeing, this change. And what we do know, if you look back from 1990 to today, the overall incidence of cancer deaths, all cancer deaths in folks under the age of 50 has declined dramatically. It's down 44%. It's amazing. It's almost a 50% drop since 1990. But not for colon cancer. Nope. For colon cancer, we've seen a rise on the order of 2% per year of new colorectal cancers in folks under the age of 50 consistently. This is a trend that's gone up, and it doesn't show any sign of slowing down. Furthermore, we're seeing an increase in mortality of colon cancer in this subset, the young, the under 50, on the order of 1% per year. That's how much mortality in this demographic is rising in young Americans. And so much, it's gotten our attention so much so that we have lowered the age for screening for colon cancer. So we used to say, get your screening colonoscopy at age 50. Also, another time for everyone on there listening to this podcast at home or in your car, turn up the volume. It's now 45. It is so because we are seeing this alarming trend.
What do you think is causing that? There's been some things that have suggested the dietary changes or kind of lifestyle type impact, and then I want to understand, Is it the screening piece? Like, is it that people aren't aware that they need to be screened?
So why are people coming down with colon cancer? We theorize, or why is the rate specifically increasing? Honestly, and I want to say this out loud, truthfully, we don't know. We do think, just like you suggested, it could correlate to a more sedentary lifestyle. It could correlate with obesity. It could correlate with processed foods and or a combination of these and other environmental factors that we fully don't understand. Importantly, no matter whether we know it or not, what we do know is that 80% or more of colon cancer that I see and that we see across this country is known as sporadic. Basically, it means just random chance. So, and I will get in my clinic many patients that come to me say, Doc, why do I have colon cancer? It doesn't run in my family. And
Mhm.
I say to them, you know what? That's how I see most colon cancer patients. It is not something that always runs in the family. Granted, there are a subset, that other 20% or so, where there's a family history, then we haven't identified the gene. There also is even a smaller subset where it's a known genetic mutation. But the take home, the takeaway from this is that by far and away, most of it is sporadic, meaning there is no family history and there is no genetic mutation. And you just got it sort of by random chance, albeit these environmental factors do play a role.
And then do you think people are missing early symptoms? Could you maybe talk about early signs and symptoms that may prompt someone who may not yet be 45 to be evaluated?
Yes, that's great. So first of all, what's very important to understand is I can't look and see my colon. I don't know what it's doing. I can't feel it. I can't sense it. You and I we don't know what's going on in our colon. That's half of the problem, because if you wait for symptoms to develop, that often means that the tumors have time to grow, and we want to catch it all early, right? Name of the game, catch the cancer early. So this is your reminder that if you meet your age-defined criteria for screening for colon cancer, you need to just have that procedure done, get screened and checked, because you may have no symptoms. This is not a drill. You may have no symptoms. Many patients are not aware they have a tumor. Okay. I would say the vast majority. But you did say, are there symptoms? And yes, there are. And those symptoms can be changes in bowel habits. That probably gets my attention the most. If somebody says, I'm usually regular and my bowel movements are once a day or every other day, and that's been normal, and now I've had a change in the last month, that's an absolute indication to get your colon checked in a colonoscopy. Obviously, bleeding in your stool, especially if it's mixed with the stool and not bright red blood that often is hemorrhoidal in nature. But I think that's for a clinician to figure out. So if you see any blood when you're having bowel movements, or something dark and you're not sure about it and you think it may be blood, call your doctor, go see your PCP. They will sort things out. They can check you. We can get you, screened early. You absolutely can do colonoscopy. We absolutely do them for folks who are not just 45 and up. We'll do it on the 30-year-olds. If you have symptoms, we will do a colonoscopy and check. The other one is diarrhea, abdominal pain, and anything related to your intestinal tract that you feel is a change for you. That's important to kind of emphasize.
Yeah. Well, thank you for that. I want to kind of tie in the last couple of conversations into what I heard from you. One, while cancer is scary, we have a lot of different things we can do when we find it early, and the survival rate's significantly better when we find it early. So two, that means screening is really important. So if you're eligible for screening, get the screening done. Try to do the best screening possible, which would be a colonoscopy. If you're fearful of it, maybe do something in the interim while you learn more about why you should really have the colonoscopy. And then the last thing that we just talked about is really don't take for granted changes in your symptoms. So if you've got bowel changes, if you've got blood and stool, don't just assume that it's maybe something that you ate or that it's hemorrhoids. Just get these things checked out.
I think those are really great takeaways. The only other one that I want to add that I didn't mention is not only do we have great new technologies in the operating room, right? We also have great new sophisticated treatments that are a category of medicine that we call targeted therapy. So remember, we said that cancers have their own DNA, just like I have DNA and you have your own DNA. We can examine that DNA for specific, let's just call them targets. And if that tumor has or exhibits that target, we can give very specialized treatment. And really, over the last 3 years, we've seen great advancements in what we can give and really looking in a more precise way at the DNA, the signature of that DNA, and then modeling treatments with very effective so-called targeted therapy that by targeted in lay or in simple terms, we mean rather than zapping your whole body with chemotherapy, that chemotherapeutic is a very sophisticated kind that just goes after the tumor. And we're seeing wonderful results with these newer targeted therapies.
We have one topic left to talk about, which is, what can each of us listening do to, in terms of lifestyle and habits that may help us prevent even development of colon cancer. If there's anything that we can all take home for that, I'd like for you to share your perspective on that.
Most of us believe that what is a healthy diet, okay, and what is a healthy lifestyle. So don't smoke. If you're smoking, try to get in a smoking cessation program and talk to your doctor about that. Do not drink excessively. We're not saying alcohol necessarily causes that if you go out and have a drink every now and then, but if you have a problem with alcohol, you should definitely cut back. Exercise regularly, and that's not just once a week. You should really exercise 5 to 7 times, weekly, for 45 minutes. That's really what's recommended, and this is great for your cardiovascular health. And it keeps you leaner. Obesity is a rampant problem in America, and exercise is an important part of that solution. Before we go reaching for other medical options, always remember diet and exercise are, a first start in curtailing obesity and weight gain. The other thing in terms of diet, people say a Mediterranean diet. I say basically eat foods that are lean, okay? So chicken, lean meats. Um, Obviously for colon health, ample raw fruits and vegetables, all brand cereals. Why all brand? Because they're fortified oftentimes with fiber. And the goal for your colon health is drink 8 to 10 glasses of water daily, 8 ounces each. In addition, try to get to the goal of 25 grams of fiber daily. Fiber and water are the healthiest thing, we think, for overall colonic health. They're also good for your overall health as well.
Thank you for listening to Living Real Change. To hear more stories from across Piedmont Healthcare, be sure to subscribe and watch for upcoming episodes. For additional health tips, news, and resources, visit us at piedmont.org/living-real-change.